All right, so 57-year-old female presents with nausea, vomiting, diarrhea following chemo. Here's her old EKG. And she comes in with this. So, narrow or wide? Narrow. P waves? Hard to say. So what's a good medication? Let's say she's stable. What's something that's a reasonable thing to give her and see what we get out of it? Could give low pressure. That's an option. You could rub in the neck. You could give low pressure. I would probably go for Adenocard, because what Adenocard is going to do is it's going to break this, right? So it's going to say, all right, no more QRS, and I'm just going to see what's coming from the top of the heart. So here it is. So now what's going on? So here's the rhythm she was in before, right? And now I see, what are these? Flutter waves, right? So they're at about the rate of 300, maybe just a touch slower. And so the flutter waves go through. So think about it. When we were talking about all the different types of SVT, you got to think about the mechanism of how they're occurring. If it's a sinus tachycardia and you block the AV node, the nice thing about Adenocard is it's pretty straightforward what it does. You think about the conduction system. If you just turn off the AV node, then whatever's going on up top can keep doing its thing, right? Whatever's going on in the bottom can keep doing its thing if it's independent. So if you're a VTAC and you stop the AV node, you're still VTAC, right? It's going to keep doing it. You wouldn't have any retrograde conduction, but generally it doesn't matter. So in this case, from the top, it's circling around the tricuspid valve. It is independent of the AV node, circling around the tricuspid valve. So if you block the AV node, it's going to keep circling around the tricuspid valve until your AV node turns back on, and then you'll go right back to this. All right? Sinus Tach. It probably wouldn't be this fast, but it would have the same type of thing. P wave, P wave, P wave, P wave, P wave. And if you went to the QRS, you were Sinus Tach, you give Adenocard, QRS gets blocked, but the sinus node keeps doing its thing, right? And so you just see P waves marching through until the AV node kicks back in, and then the QRSs would come through. Atrial tach. Same idea. It's a focus in the atrium, and that focus is irritated for whatever reason, and so it's going to give you impulses, right? If I block the AV node, that's independent of that focus, it's going to keep on firing, and you're going to keep on having P waves until the AV node wakes up again, right? So sinus tach, atrial tach, we talked about flutter, AFib, same idea. The focus, though, is not just one spot, it's a whole bunch of them. And so if you give Adenocard to AFib, you're going to end up with fibrillatory waves, and so you might see an irregular baseline, and when it comes back, it's going to come back in fib, right? So really the re-entrant tachycardias that involve the AV node are the ones that are going to respond to Adenocard in a positive way, where you would see block of the AV node, no more QRS, and a flat line. And then you see a P wave and a QRS once it kicked back in. So that's Adenocard, and it's important for you guys to understand. So this is actually later on. So we gave Adenocard, we saw that it looks like she's in flutter. And then later on we did an EKG. So what do you think, narrow or wide?
Yeah.
Yes. So the same idea. So what do you think about the PR interval? A little bit long. So you think this is just a first degree AV block and that's it? Yeah, so you got a little extra guy there, right? So you got to explain that. So now you march it out, P, 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 P. So it marches all the way through there, right? So this is that atrial tach kind of idea where it's marching through. So whether it's an atrial flutter that's circling around some structure, there's typical atrial flutter circles around the tricuspid valve, the annulus of the tricuspid valve. Atypical flutter circles around another circuit, whether it's in the left side of the left atrium, right, whatever it is, it circles around. And it's the same principle. It just goes around that circuit, and whenever the AV node is ready for the next impulse, it goes down. If it's not ready, it just keeps circling around. Atrial tach is just one focus that just fires, right? And if the AV node is ready, it goes down. If it's not, it blocks. And so this, hard to say, it's not at a rate that looks like typical flutter, unless if the patient was on a lot of, maybe they're an amnio or something that slowed down that rate. But otherwise, I would lean towards an atrial tach, but also recognizing that it definitely could be an atypical atrial flutter. Fair? All right. So the telemonitor. So now what? First degree AV block? What are we missing? We're missing water. Okay, P wave in here, right? You can see it?
Yep.
That QRS is a little bit longer than it should have been, and it has kind of that slope. And if you march it marches out with P waves. And we know that because we just saw it on the previous EKG, so that helps. But with this, actually with this patient, she was on telly, and the thought was she was just sinus tach with a first degree AV block. So you could easily miss that. But every once in a while she would kind of skip a QRS, whether it was from a PVC or something, and the P waves would kind of come out and they would show themselves. So the other thing you could do is you could rub on the neck, right? So here's a carotid massage. So same thing we saw before. The P wave is here, and there's actually an extra P wave. Now the P wave came to the front of the QRS. So the AV node is saying, I'm not ready, and there's some disease there before it conducts. And so you see the P waves marching through, and now you rub on the neck, and you produce an overwhelming vagal tone, and that tells the AV node not to accept another impulse. So now the AV node's like, I'm not having any of this until here. And then it's the same thing. I'm not having any of this till here. And then you're done rubbing the neck, so it gets back to a normal thing. Pretty cool. All right, 59-year-old with chest pain. So we just did a whole bunch of these. So hopefully you guys are on to this. ST elevation. Where? Inferior leads with reciprocal changes in 1 and with changes in V1 and V2 that are concerning for posterior, right? Okay. So following PCI to the right, now you can see there's still some changes. I think the point I want to make from this is most of the time after we open up the vessel, you'll get rid of the ST elevation. There are cases where we've taken people back down and the vessel is still open, but they still have ST elevation. It might be a microvascular kind of phenomenon, maybe some clot showered down and filled up some of the little vessels. But that's something that happens. The other thing to consider if somebody still has ST elevation after an intervention is maybe there's an aneurysm, a weakness in the heart muscle that's causing the ST changes that you see after the intervention. So I kind of want to make that point. And post-op day 1, so now we talked about the evolution of an MI. You can see these T waves and how they're inverted, right? So that was part of that evolution. And now we're on to the next one. 55-year-old female, knowledge about many times 4 days. ER, all right, when you're in the ER, what is this? When I see this EKG, you're going straight to certain kind of medications to reverse what? Hyperkalemia, right? So when you see the QRS complex that wide, eventually if you let this keep going, their potassium gets even higher. This becomes like a sinusoidal kind of thing, like death, basically. And so you don't want to get to that point. And so in this case, when I was on ER several years ago, we had a patient similar where we just started treating for hyperkalemia before even getting labs back because it's that diagnostic. And in that case, it reversed. And so so we gave insulin, D50, calcicluc, caxylate, and ordered dialysis. Well, dialysis takes a while, right? So you got to give all these other things to shift the potassium back into the cells. And so you can see a much improved EKG overall. You're kind of wondering about the P waves and where those P waves are. And so I would think about a junctional rhythm in this case, which is something that can definitely happen with hyperkalemia. Okay, potassium here, so 9.2 on admin, and then the repeat goes down to 7. Now you're starting to see some P waves coming. That should get better. 49-year-old. Here's a baseline. So P waves, narrow complex, and looks pretty good. And what do we have here? So the P is kind of encroaching on the QRS. So when I see that, I think of several things. One is an accessory pathway where it's going down the conduction pathway and bypassing the AV node. But if I saw that, I expect that to be pretty much regular throughout. It's kind of changing, right? It's close and it comes further away. And so the thought here is that the QRS also has different morphologies, right? Like that one looks a little bit different than these other guys. And so there's some sort of AV dissociation where maybe that one captured but these other ones didn't. It might have been the timing of this P wave came, but a ventricular source came up sooner than that P wave could go through. So that's something to consider as well. Old EKG, 48-year-old female. Chest pain on presentation. All right, where's her issue? Inferior leads look okay, so V1, V2, V3. So she ended up with an LAD lesion. And you can see here, post-op day 1, now we're starting to see these changes that we saw when we saw how an ST elevation evolves, right? You see ST elevation followed by T wave inversion. And you're also noticing that we're losing any R waves up in these leads. So they're pretty much cute. Maybe there's a small R wave there, but they're kind of cuting out. And that's from damage to that muscle. And then this is after bypass. So you can see the T waves kind of came back. It looks pretty reasonable. All right. I think, you know, let me quick go. That's good stuff. I want to make one more point before you guys go. All right. This, what's this? Because you guys need to be able to do rhythm strips, of course. Wide complex. Okay. Sinus. You got P waves in there. Maybe. I mean, there's one there. There's one there. There's maybe one there. Right. There's something kind of goofy going on with the maybe some AV dissociation, but I think overall there's P wave, there's P wave. But what are these? This is what I'm interested in. Yeah, so are they narrow, wide? Wide. Do they look the same as these? They're different, right? So it's coming from a different spot. It's not like this just took off and got faster. This is coming from a different spot. So this looks like a short run of NSVT. Now it's the same BTAC, 6 beats, right? See that quite a bit? Up on the floor. What about this? Wide, narrow? Wide. And so you got several beats in a row. It's very regular. The initial activation of the normal QRS goes up here, it goes down for the most part. And the T wave, you know, big, it just looks like a PVC, it looks like several in a row, so that's NSVT as well. What about that? So 2 of them in a row, couplet. What about that? Okay, what else?
Kind of hard to tell because that could be garbage too.
Yeah, exactly. So this is what you guys get used to because the monitor keeps beeping all day, right, when you're on telly? And so if you look, you see there's something here, there's something here, there's something here, there's something there, here. And so you start to see that, you know, there's these blips that are interrupting this craziness. And so this is all artifact. It helps when you have the entire picture, right? So I deleted this so that you guys couldn't cheat, and I just gave you the top. But if you see this, so if you focus on that, it does kind of look like torsades, right? But it's not, because you're looking here to say, okay, there's QRS, 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 QRS. Okay, so that's artifact. That was AFib. What about this? Shock them. But then they're like, no, don't shock
Check
me.
the patient first.
Don't shock me, right? So again, overall, if I take a step back, there's something going on in these QRS complexes, maybe these big ones here. And so this is artifact. What helps though is to be able to look back here and see, okay, they were in normal rhythm and they started moving and all of a sudden they started moving a lot and then they're back in normal rhythm. You know, they weren't in torsades for like 6 seconds. So. All right, that's AFib. I feel like this is another thing you guys need to be good at on the floors. Just look at the baseline. You don't see a definitive P wave. It's irregularly irregular, and so you're going to go with AFib on that, rather than, and the other differential would be MAT. All right, you guys have any questions? I don't want to keep you too much.